apologize for the technical difficulties. It seems like every time we do this, it's something new every time. So no matter how many times we try and test run it, something always pops up. Okay.
Good morning.
Good morning. Was that Lisa? Yes.
Yep, it's me.
Okay. Well, good morning, everybody. Thank you for taking time to be here today. I know this has been kind of a long month for all of us, pondering some decisions, but we'll go ahead and get started. I do know that Julie's going to have to cut out about 9:55, so hopefully we don't have to worry about that to that point. She's supposed to meet with the retirees after this. Hopefully we get through her presentation. We've got a couple of presentations from Cigna today and also an update from Lockton as well. So did everybody get the meeting minutes from, I guess, August?
Mike, I'll make a motion that we accept the minutes.
Okay, motion made by Jeff.
I'll second.
Seconded by Jamie. All in favor, say aye.
Aye.
Motion is approved. Kimberly, are you on this morning?
Yes, I am.
Good morning. How are you?
Everyone should have the financial report from August. And as I think Julie or Amber, someone sent out that August was not a good month. It was the largest month for claims. So for August, the OAP1 plan had a net loss of $938,677. The OAP2 plan realized a net income of $109,996. For the second month of the fiscal year, we're experiencing a loss of $1,263,937. So your ending unrestricted net assets, your fund balance basically is $2,038,066. Does anyone have any specific questions about the? I know we are getting, I think this week, I think it was like $250,000 for the prescription rebates coming in around that ballpark. I didn't look at it too close. So I'll have to verify that it comes in at the bank, but it seems like it was about that much from Julie said.
Okay. Does anybody have any questions for Kimberly over the financial report? Okay. Do we have a motion to approve the financial report?
I'll make a motion to approve.
Jamie makes a motion to approve. Do we have a second?
I'll second it.
Seconded by Jeff. All in favor, say aye.
Aye.
Motion's approved. Sorry, I guess we're having some technical difficulties with the water department. Tammy and Mike Labor are having some issues, so they're texting me as we go. Next update is going to be from Cigna. Lisa, do you have any updates, or Julie? I know, Julie, we're going to get to your presentation under new business, so.
No, I'll make it short. No updates for me.
Mike?
Yes, ma'am.
Do you want me to talk about kind of the quick update and want me to talk about large claims during this time?
We can, or we can save that under new business. Add it into your presentation with the pharmacy part. That way we can get to Lockton's part, and they can actually talk a little bit about the large claims so that we can see those. And then if you want to tag in on the
How
back.
about if I just comment on high-level code info?
Okay. Yeah,
Am I
Julie,
okay?
you have a
So-
lot of echo this morning.
We
Yeah,
have-
Julie, your audio is really bad.
8 people and 19 have been positive.
Julie, your echo is really bad to the point where we can hardly understand you.
Yeah, and I'm not sure why. Let me see if my volume is on.
Lockton, believe you are up.
Yep. How is my echo? Is that okay?
Sounds good.
Okay, awesome. All right, well, as I said on Friday when I sent the message, August claims are not favorable. They're not pretty. Gross medical claims were 1.7, which is the highest month thus far in 2020. Oh gosh, so we're looking at total plan costs of $2.27 million year to date on a PEPM basis. That's 1,464. So this time last year, that was 1,112. So on a so that represents a 32% increase when you're looking at claims on a per employee per member basis. Of course, we are now looking at per member per month due to the fact that post 65s have been eliminated from the plan. So when we look at that year to date, that average is $613. And this time last year, when you're looking at the claims on a per member per month basis, it was $511. So we're looking at a 20% increase. So the point here is that on a PEPM basis, it's higher when you factor in all the members. It's a little bit less of an increase, but nonetheless, it's still a 20% increase in the member per month basis. So large claimants is where we did a lot of digging to figure out why, to try to delve into why the plan is running as it is. So if you go to the last page of the experience report, you'll see that there are 11 members with claims over 150,000. We've got just one that just hit this month that's over spec $14,000. So this time last year, we've had 10 folks over the 150,000 threshold, 3 of which were over the pooling point by 328, almost 329,000, excuse me. So really what we're finding is there's a lot more large claimants that are in, there's a lot more large claimants that are not, that are in that one, that lower range. They haven't hit the threshold yet. So you're not quote unquote benefiting from the amounts over stop loss. So Julie had alluded to, I had asked her to see if she could dig into the claims and figure out what was going on. And since she's got an echo, I'll just chime in with what she shared with me. She said that she saw about $900,000 in 18 new large claimants in just August. So I want to repeat that, $900,000 in 18 new large claimants just for August. One of those folks had sepsis at 289,000. And then if we further break that down, about 500,000 of that increase was 15 claims under the 60,000 threshold, and more than half of those were under $30,000. So Dina also, this is a lot of information, but we wanted to come armed with, since the plan is not running favorable, we wanted to come armed with as much information as we could as far as what we found in just reviewing the data. So Dina had done an analysis of large claimants, eliminating eliminating those folks that were 65 and older from 2019 to 2020 to do a year-over-year comparison. And really at the end of the day, I mean, it's supporting what we've been saying is that there's more utilization, but everything's under that specific threshold. So for instance, under the 25,000 threshold, this time last year, there were 90 claimants at $6.5 million. For August, it's an increase, it's up to 103 folks at about $7.5 million. So it's representing about a 15% increase. And then really the largest increase that we saw in the certain thresholds were the amounts over 150,000. There were 9 at this time last year with $2.2 million, and then 11 folks at $2.3 million. So that was a 22% increase in terms of members. So a lot of information, but hopefully that helps quantify, if you will, what's happening. So I will pause there and field whatever questions you may have on the information we presented.
Do we know, you're talking about the claims under about $60,000 and specifically under about $25,000.
Mhm.
Are those people just going to the doctor? Are they going to the ER? Or are they having procedures done? Do we know anything like that? So maybe we can kind of work towards gearing towards that situation to kind of help lower those costs a little bit.
Julie, do you have any, I know that you did the digging on your data since you've got all the raw claim data. Are you able to speak to that, or would that be a follow-up for you?
So can you hear me without an echo?
Yes.
Yes.
Yay! Hallelujah. Sorry. Okay, so I can kind of run down. We have it looks like a knee surgery. And I'm kind of just doing, so my report is anything over 25,000. So actually let me kind of highlight the new ones. So one of the new ones is, because that knee was already on in July, although it did increase a fair amount from July. We had a fracture that was like 38,000. Had something else which looks like it was someone who was nauseous, so that could have been potentially a COVID situation or a other type of situation. It was coded, it wasn't coded as COVID though. Had a prostate cancer, had looks like this was dermatitis, which may have gone into cellulitis. I'm not sure on that one because it doesn't give me, I've only got so many letters in my little explanation here. Intracranial and intraspinal phlebitis. So stuff is not pretty when, appendicitis, Crohn's disease, another appendicitis, looks like a substance use disorder, and an aneurysm. We've got a COVID claim of 28 on here. We've got a goiter on here. There's another COVID, which is about 59,000. So the short answer is, Mike, it's not ER stuff. It's not, it's more complex. And so that's why it's hitting that more than 25,000. My guess is that some of this stuff, either because, for example, if it's an elective surgery, it was probably postponed, and so it's kind of hitting that time frame. It could also be, unfortunately, we've had people who've postponed treatment, which in some cases, depending on maybe diagnosis of a cancer or what have you, or postponement of a treatment, some of that isn't good because it ends up, being a more expensive claim than it would have been had they been able to go back in March. So those are some of the details. And then, the people that were already on the large claim report, we've seen some increases as well in what increased dollars that are coming in. We've also seen a little bit of a delay on, and we've kind of talked about this all along, and so has Lockton, but just some of the providers were so overwhelmed during COVID that they weren't necessarily getting their stuff in timely and or coding it correctly. So we may see some of that. So hopefully that's helpful.
it kind of gives us an idea of where everything's coming in. I mean, if there were certain areas that we could work on as a committee and as a group to kind of help drive those claims down a little bit and offer some resources, we could. But it sounds like it's just everything's catching up from the beginning part of the year where everything was shut down. So, well, thank you, Lockton.
Yeah, I wish I had better news to deliver, but
Does anybody have any questions for Lockton?
I'll make a motion to accept the report.
Jeff makes a motion to accept the report from Lockton. Do I have a second?
I'll second.
Jamie seconds the motion. All in favor, say aye.
Aye.
The motion is approved. HR. Terry or Jennifer?
This is Jennifer. Good morning.
Good morning. How are you?
I'm well. How are you, Mike?
I'm okay, thank you.
I just wanted to make sure everyone saw the Hy-Vee clinic email went out, and we should have gotten them in the mail as well. I know I got mine at home in the mail. We've had some feedback about it. We've had some questions, and so Lisa is actually fielding most of those questions. There was one question that has come up a couple of times, and that's if we're still going to have that hour of, paid. I think there was a clinic pay code, or there is a clinic pay code, and we are going to let people still have that hour if they need to go run, get a flu shot or do whatever they need to do. So we decided that we would still do that. We are going to put that information in the open enrollment as well, and kind of expand on, hopefully, so we can answer some of the questions that have been coming in, but wanted to just let you all know in case your cohorts ask you that question. And then the other thing is we're just, trying to get things ready for open enrollment next month.
Okay. Yeah, that's something that we may have overlooked as far as, because I know everybody was allowed to go to the clinic. And yeah, we appreciate that. I mean, that's a huge help as far as some of the employees here in the city being able to go and have that hour. So it's nice to have that benefit.
Hey, Jennifer, this is Jeff. Would you be able to email me a copy of that Hy-Vee letter, since I don't get those? That way I can at least put it in my file, and if I have questions, I have something to refer to.
Absolutely, Jeff. I'll do that this morning.
Thank you.
Jennifer, I didn't get it either. This is Cindy.
Well, Cindy, of course, I'll send it to you as well. And then I think Terry is planning on sending it to the pre-65 folks will be able to use it because they're on our health, they're in the Staywell fund. So I think Terry's going to send something out, and then also that'll be in the retiree information as well.
And that's
Yeah, I'll
something
get
we
that
can
out
really-
today to the retiree list.
And that's something, Jennifer, you said that we were going to make sure we had for open enrollment and really push that.
Absolutely.
Awesome. Thank you.
Uh,
Anybody have any questions for HR? Okay, thank you. Selena, wellness.
Hi.
How are you?
Good. One thing I wanted to mention about that email and the letter home that got sent was it does mention the flu shot. So I've had a few people email me and ask about the flu shot event. So if you guys get an opportunity, just let them know we're not doing an on-site event. They can go to Hy-Vee. They also can go to their own primary doctor. But I do know that it was mentioned on that email as well as when it was sent home. But I'm still having some people get a hold of me and ask me, are we having the event? And if not, where should we go? So they can go to Hy-Vee if they would like. They can go to CVS. They can go to their primary doctor. We just won't be having one on site.
Sorry, I don't mean to interrupt. Lisa Phillips, She actually talked to one of our employees. Can you tell them about the Hy-Vee clinic? I think it's the one at 23rd here in Independence, about they have the drive-up service. Would you mind mentioning that real quick?
Yeah, so basically, one of the employees went to the 23rd location to get his flu shot and was told that they also offer a drive-through service for certain hours of the day. So I thought that would be beneficial for the employees in case they need to have, if they need to use their hour, they can go in during work hours and get services done. So I thought that was pretty neat. And all they need to do is just fill out a consent form online and then have it with them when they go in. So I think that's a great information that we can promote to the employees and pre-retirees.
Hey, this is Jeff. Hey, on that drive-through flu shot, Hy-Vee does them on Mondays from 7 a.m. to 11.
Right.
On Thursdays from 3 to 7, and then on Saturdays from 10 to 2.
Correct.
Also, I know that the CVS here in Blue Springs, they do it as well. They do a drive-through flu shot clinic as well. So
Right.
I'm sure it's not just Hy-Vees. I'm sure it's a lot of them getting on board with not having to come in. You just drive through with a consent form. So there might be the CVS that's located right next to Hy-Vee. They might be doing it as well.
And the other thing was setting up an appointment. This employee mentioned that he called to schedule an appointment, was on hold for over an hour. And I know that was a complaint that most employees had with the Staywell Clinic, was that they couldn't get an appointment in, or if they did, they had to wait a month. But in this case with the Hy-Vee clinics, it's just walk in. So you don't necessarily have to schedule an appointment to be seen. So you can just easily just walk in and get serviced. And he said it was quick. He said he filled out some paperwork, which is paperwork you can register online in advance. So that way you can get that part of it done prior to your visit going in. So all this information Terry and I discussed, and we will have all of that information on the benefit guide so they know exactly what they need to do to get service there.
Awesome. Thank you for all your work and getting this going. I know every time we do something like this, it's an undertaking, and there's a few hiccups along the way, and I appreciate everybody being flexible and getting this program up and running. I think it'll be a huge benefit once it's running smoothly in the next few weeks. Selena, did you have anything else?
Besides that, today there is a blood drive. It's over in Truman Memorial Building at the Presidential Hall. They are taking walk-ins, but so if any of you guys want to go get one or are on site, if you are not on site but you go to a community blood center, you can still tell them you're doing it for the Independence blood drive. So that is happening today for the employees. And then we're just trying to get the information out about the biometric screening and health assessment. So we're continuing to send some of that information out. So, and then just working with HR on the benefit fair, virtual benefit fair, the stuff we're going to offer for the employees for the benefit fair. So.
Great. Thank you, Selena.
You're welcome.
So we'll continue to old business. Lockton made a presentation last month on the reforecast and the projections for 2020 and 2021. And then I believe Dina and Amber sent out an updated reforecast projection and some plan options to look at. So I'll let Amber and Dina kind of take over and walk us through their presentation, and we'll go from there.
Okay, well, hopefully everyone got that. Basically what we've done is we've updated the reforecast and the projection using claims through August and kind of showed a range. So we use claims through March and then claims through August. And if you look at it, there's quite a big difference between the projected deficits for depending on what months you use. So this is the problem of COVID-19. No one knows exactly what months are credible and what months are not credible. And so that's why we are very conservative in our analysis and are showing the range. On page 2 of the presentation, if you have it in front of you, we have the range of a deficit of between 200,000 and almost 2 million. So that makes it very hard for budgeting and planning, but not sure, other than the COVID issue, I'm not sure what else we can say. It's likely going to be more towards, given if the claims for August continue throughout the remainder of the year, it's going to be closer to that 2 million. But August was a particularly bad month. On the projection, we have not gotten the stop loss renewal yet. Our stop loss team has anticipated that it will be about 15%. Julie, I don't know if you know any more about that at this point.
I think we were targeting in October, early October, so probably be a couple weeks.
Okay, so we use that 15% increase for both of these. We do have the updated rebates for prescription drugs and anticipate that those will increase about 15% based on the enhanced contract from Cigna. We know that administrative costs and access fees are going to remain flat. Went ahead and put a 4% increase for vision claims. That's a little high, but anticipate that particularly using the claims through August, that there was some delay of care for vision, even more so than medical, because it's just less urgent. So using that, we anticipate that you need an increase of 14.5% to 20% in the funding rates. At current funding rates, we anticipate that 2021 will end up with a $2.5 to $3.5 million deficit. So then moving on, we just ran some plan options for the two plans, mostly increasing deductible and out of pocket, because those are the areas that you're going to get the most savings by making a change. Increasing copays don't really do a lot, don't really drive a lot of savings. So kind of focused on the big ticket items to start out. So right now, your deductible and out of pocket on OAP 1 is $800 and $3,000 for an individual and 2.5 times for a family. So the first option just shows what that would be if you moved from 2.5 times to 3 times for the family, and increase the family deductibles from $2,000 to $2,400 and the out of pocket from $7,500 to $9,000, and that would save about $42,750. As you can see, moving down the column drives more and more savings, but it's more and more impact to the members. So if you increase the deductible and the out of pocket, so the deductibles from from 800 to 1,000, and keep the families at 2 times versus 2.5 times. So it's showed, so it's the deductible and the out of pocket increase are shown for the individual, and then they're shown at 2 times, 2.5 times, and 3 times. So I have the same numbers twice there, so obviously there's an error. But you can see that that's what's going to drive the bulk of, or the most savings. I won't go through each line. We can kind of talk about, I'll let you all talk about where you want to go, and we can hone in on it based on that. The plan 2 options, we did look at increasing the deductibles and out of pockets on that one as well. For all except the last line, the deductibles and out of pockets remain non-embedded, which means the full family deductible and out of pocket have to be met before any benefits are paid on an individual. The last option, moving to a $2,800 deductible, actually makes it an embedded deductible. So each individual stops at that $2,800 or $4,000 in our example, and then the family is the combination with no individual being over that $2,800. So, not sure where you want to go here, not sure where you want the discussion to go. happy to talk through whatever.
May I ask a question? This is Jennifer.
Absolutely.
Would it be fair to say that since we doubled the amount of participants in the OA2 and it's still running in the green, that would maybe be something we would want to consider, is to keep encouraging people to go to that plan?
Yes. So there's a couple of comments there. The claims are going to be the claims regardless of which plan they're going to be in. So the difference between the OAP 1 and OAP 2 is, one, the employee cost sharing amounts, and two, the OAP 2 should be driving a little bit better consumeristic behavior. Our models do not take into account any of the consumerism behavior changes, but what we see is that early adopters in the OAP 2 plan generally are healthier individuals because they have less fear of that deductible. So there's probably a couple of different things going on in there, Jennifer. One is probably your population in there is overall more healthy at the moment because those are the early adopters, and maybe a little bit of the consumerism behavior, but it generally takes a couple of years for that consumerism to really kick in. Does that mean you should not? I mean, I still think that moving to that, promoting that plan is a good option, regardless of all those other comments. Does that make sense?
Yes, absolutely.
The other population that tends to migrate to a high deductible plan is the very sick individuals, because if it has a lower out-of-pocket or you're going to reach your out-of-pocket regardless, you might as well go with a lower cost plan if you're going to have the same out-of-pocket regardless. And so people kind of run through those analyses on their own to come up to that conclusion. But unfortunately, a lot of healthcare is not anticipated. So that's the other side of it. You don't know, a healthy person could have an accident and be in the hospital without really planning on it. What other questions can I answer?
It's just a lot to take in right now because we're going to have to make some big decisions on this plan with going to open enrollment next month.
Jennifer, let's ask you from the city side, because clearly we don't have Brian or Adam attending these meetings, but if we need to make an increase to save this plan, is that going to happen? Because there was nothing budgeted.
Well, I think, I think you have to look at everything and make an informed decision. We have to do what we have to do. I would like to think we have options. Maybe the increase doesn't happen on 1/1. Maybe it's something that you look at for 7/1, and then you have a few more months of claims, and you have, it starts a new fiscal year. I think there's options once we, kind of run through everything. But at the end of the day, you have to propose what you believe is best for the funds. So, but I do think there's options that you can play around with. But you're right. Nothing was budgeted for 1/1. That's for sure.
So I'm going to ask the question, and I know it's a touchy subject, and we've been through this before, and I'm not sure who can answer it, but is there a potential that we're seeing some of these increases and that's potential deficit due to the plan changes that have been made over the last couple of years, mainly the post-65 retirees and the clinic as well? I know on paper it was saying that we were losing money on the clinic, but it was always something that we could never measure the cost savings of the clinic. Is there some way that we might be suffering from that now? I don't know if it's something we can measure or not.
We could probably, I'm going to speak up, Julie. We could probably run a report of like primary care utilization from last year to this year and see what the plan has paid versus what the clinic costs. That would be the only way to measure the clinic. Is that something you could run, Julie?
So we can get data on primary care that's been running through Cigna, and but we won't be able to. It would be, as you described, Dina. Excuse me. We would compare that to clinic data because clinic data wasn't coming over to us directly. So we may have to do some finagling with that. I think, you know, we can definitely pull that. And in our most recent analysis that we did, I mean, some of this stuff, and preaching to the choir here, but you know, some of this stuff is long-term, you know, chronic member issues driving a lot of this too, because, you know, there were 46% of the population had a chronic condition and drove 77% of the trend. That was our one of our comments from one of the recent annual strategy meetings. So it's, some of this stuff is long-term in nature. It doesn't make it easier to swallow because right now it's staring everyone in the face and it's a difficult situation. So, but we can pull data on preventive and see what the utilization was.
Okay, I have a question, and it relates to some of the chatting that's going on. My understanding is that you're saying that a lot of the increase in the claims, we had a really bad month in August, and we really don't have enough information to understand why. It could be COVID, right? And most likely might have some stuff to do with that. But I heard you say that there were not a ton of emergency room visits, that's not what made the increase. So I'm not sure I totally agree with the chats that are going on, but also there was a huge savings from the clinic. So you have to put both of them in, that what it cost and what the savings was. And I thought you did that analysis, Dina. Can you speak to that or no?
Yeah, well, I know this. That's what I was going to say. If we could see the year-over-year increase in cost with primary care and compare that to the savings from the clinic, then that would give us a better idea of if that's really impacting the plan. Our numbers did not include the clinic. It's only the claims paid through Cigna. So our numbers do not include the HSA contributions. They don't include. They didn't include the clinic. So we're just looking at medical claims versus medical claims. So yes, that would be a part of this increase. But on the flip side, the fund would be saving money by not paying for the clinic. And so in order to really evaluate that, kind of need both pieces of that puzzle.
We'll pull the preventive data.
I'm not disagreeing with what you're saying either, but at the same time, we have a responsibility on this committee that we have to look at all aspects of this. We need to figure out where we're bleeding from and try and fix it. And we have to look back at some of the changes that have been made. And did those changes hurt us? Can we change? What can we do to learn in the future so that we're not in this situation again?
I agree with that. And I would also agree with the 60, the post 65, that's a large population that comes out of the plan. Yes, those costs come out, but also their premiums, the revenue piece. So there was probably an impact there, but I would argue that would be more of an analysis than maybe the clinic. Again, I would caution, you need to look at everything when you're talking about what Lockton is showing is real data, but it's one piece of the overall picture of the fund.
And I understand that, but we have to look at it too, that, for 5 years, when we were running this plan, we never had a premium increase. We've managed to run it. And then the last 2 years, there's been changes made to the post-65 retirees and to the Staywell Clinic. And now we're getting hammered with premium increases. And I understand that that's not all attributed to those changes, that there's a drive in the market, and insurance is going up. That's the bottom line. There's no way around it. Everything's getting more expensive. We have more claims right now, but we've got to be able to analyze and look at everything that's been done. I'm not putting a fault on anybody at this. I mean, there were a lot of people involved in making these decisions, but we're just trying to figure out where to go from here to make this plan healthy for everybody that's a member of it.
But I would argue, Mike, that, and I'm not really arguing, so let me change that wording. Healthcare costs do continue to go up. So year over year, the cost of services go up. And without any increase in the funding over those years, there probably should have been some for some of those years if you go back and look at our projections. But you know, as we look at those claimants over 25,000 and the fact that that has grown by 15% over the year, that's not necessarily only because of increased utilization from city employees or city members. It's also because, as I said to Amber, you could stub your toe and that would cost 25,000 right now. It's the cost of healthcare has gone up so dramatically, and we don't see that changing anytime soon unless you do something truly dramatic to the plan, which I don't think you're quite ready for, and I don't think would go over well in the Kansas City area, which is to move to like a reference-based pricing model where you pay what Medicare pays, but then all your members are going to have a ton of issues. I mean, I don't want to minimize it, but or blame it on somebody else, but part of there is increased costs in healthcare, and that's part of the issue, regardless.
Yeah, there's multiple factors in this, and I just want to make sure we're looking at all of it and doing our due diligence for the rest of the members on this plan. That's all I'm asking.
Sure. No, I 100% agree.
Well, and I closed the experience. Are the claims coming from dependents, or are they mostly coming from employees? That's another thing that you can look at is, you know, do you increase the cost share for dependents and families? Is that where we're bleeding? And keep it, you know, keep it more for employee only. That's something you can think about.
So 6 of the 11 large claims are employees. 3 of them are spouses and 2 of them are children.
And I would just add to that, I was just looking at that as well, Micah. The top 4 in terms of dollars paid are employees.
But you're just looking at the top. You're not looking at the list like Julie had of the ones that are hitting the 30. You're just looking at the really, really high ones. You're not looking at the overall, the ones that are really killing us right now, which is that large amount of $30,000 claims.
Correct. And Julie, do you have that handy? I can pull up the report if you don't. Or we can take this as follow-up and...
I think we can do it here.
Okay.
Let me...
Yeah, I'm pulling it up too, Dina.
I mean, I don't know if that's anything that you guys would even consider, but it is worth thinking about when you have a plan that, you know, I agree, Mike, that looks like is bleeding. And we did have premium increases on July of last year and January of this year. So we've had 2 premium increases fairly recently. But again, I would also argue that this is a very unique year. So I still, and Dina and I've talked about this, I want to be cautious because it is such a unique year. It's not like a year like anything else we've ever seen.
Oh, and I totally agree with you, Jennifer. You know, we're trying to predict the future on how this is going to go, and it's just not something that can be done. We just got to look at all aspects of it. And you're right. It is a very unique year. Had the year run normally, and we wouldn't have been able. Had we not dealt with COVID, we may be in a totally different spot. This, for example, you take the month of August when we have over almost $2 million in claims. That might have been spread out over those 3-4 months that everything was shut down. So you're right. This may level off, but we don't know.
And Jennifer, just for history purposes, we have adjusted those tiers before. In fact, we tried to encourage, the employees with spouses and families to have the spouse, take out their own insurance. And notoriously, we have had more people when we did that. We did not have that many people come off the plan where they'd go to their own, because people think our insurance is really good. So even paying the higher rate, they chose to do that instead of being forced over to their spouse's employer's plan.
Well, I mean, that's something you can make that mandatory. I mean, we could force that issue if that's something instead of just suggesting it. That's an option.
And I know that'd definitely be more conversations. I just want you to know that we have went down that road, and we did have some come off, but not a lot.
I personally don't think you want to be forcing spouses off the plan, but I also see if their employer was offering them insurance, that I can see why you would want them to go with that, but you can always add some sort of like a penalty fee or something like that. If the spouse's employer offers them insurance, they pay an additional $50 a month or whatever was decided if they want to stay on the plan. But I don't think just forcing people off to say, hey, we can't afford you, you need to go off. I don't think that's a good thing for us or the city to be doing.
I agree, Jeff. We've talked about that too, because I know, Dina, you guys have brought that back to us several times, that a lot of employers offer that they let you take it, but you have to pay a penalty for doing that. And we've just never, went down the road to see where that's gone, because we've been able to balance the plan out. But as we keep going and we have these issues, that may be something that we really do need to look at. And that is why that data would be good, not just looking at our large claimants, but looking at our overall claims, how much now is, attributed to employees or attributed to employees and spouses. Because as I said, we all know that our insurance has always been pretty good insurance. So people don't want to just drop off our plan. And I've known some that have and came back to our plan. They've took their employer plan and then they came back to our plan.
Dina, this is Dina or Amber. This would be a question for you. I know we've done mid-year plan changes, and I know Jennifer made mention that last year we did a 4% increase in January, and then we did one mid-year in July to kind of help spread that out a little bit. So we know that that's always an option to make those mid-year changes. How much of a gamble, or I shouldn't say a gamble, how much of a risk are we taking if we kind of set back for a minute and see what happens in the market, see if this plan kind of levels out? If August was just a really bad month because everything's catching up to us and things start to level off, I mean, I don't know. I'm not trying to put it off, but at the same time, I know we don't have a lot of accurate numbers to predict the future. If we waited another month or two and had some more accurate information to use in those analysis, what would that look like?
who knows? I mean, that depends on what the intervening months do. But I mean, that's fine. It's your plan. So it's the only risk is if the numbers continue to be high, that you're eating into your reserves.
And knowing that what the percentage of medical increase is taking, even doing some sort of, I mean, you don't want to do a 10% or something like that probably in January, but doing some sort of increase, it's going to be needed regardless of whether or not this thing continues. Am I correct, Dina? Because the trend, no matter what, the medical costs are going up. We're still going to need some sort of percentage to happen.
We would always recommend a slight increase. In answer to your question earlier, though, Cindy, of those 109 claimants over 25,000, 59 are employees, 29 are spouses, and 21 are children. So I just did that count real fast.
So it's about 50% employees and 50% spouses and children.
Yep.
Pretty much. Yep.
And almost evenly split, not quite evenly split between spouses and children.
And Cindy, I agree with you. I think some sort of increase is going to be necessary because, I mean, even going with the worst case scenario on OAP 1 and 2 on increases, you're only looking at a $600,000 savings where we're at a, what, $2.5 to $3.5 million deficit.
Why don't we chew on this for a minute? We'll let Cigna do their pharmacy presentation, and then we can come back and discuss all of these options once we have all the information. Julie, are you still on?
Okay. I am. Can you hear me?
Yes, ma'am.
No echo?
None.
Not now.
Hallelujah. Not yet. All right. So I'm just going to make some opening comments, and then Patrick is our pharmacist, and I will let him introduce himself once I give my opening remarks, but I want him to kind of comment and walk through the presentation. So I mentioned to, last meeting, you all wanted us to dig into pharmacy and see if there were some things that we could do. Overarching theme here is that a couple of years ago, you guys already have done a lot on pharmacy. There are a few, tweaks here that we can make. Our last annual report, the pharmacy was running at a negative trend overall. And so Patrick actually did analysis to look at the last 12 months. That was actually last calendar year. And I don't want to steal his thunder, but you're still running very well on the pharmacy side. So again, overall, you've already done a lot to position yourselves in a good spot for pharmacy. There are some tweaks that we can make. So I'll let Patrick introduce himself and then kind of go through the materials and answer any questions you guys have.
All right, great. Thanks, Julie. Can everybody hear me okay?
Yes, good morning, Patrick.
Good morning. So if you have the presentation, we sent it out Monday afternoon in a PDF. That's what I'll be going over. And I can just jump in. And just before I jump in, so my name is Patrick Ndebor. So I'm the pharmacy clinical account executive that supports Julie on the City of Independence. And I was with you at the City of Independence earlier this year with the annual review. So we're doing something similar. And the data time frame will be July of 2019 through June of 2020. So in some of the discussions that I've heard going on, we may not have full visibility on the claims in August. So we have claims from July 2019 through June of 2020 compared to the same time period prior to that. So if you go to the second page, which will have the key findings, and it's in a summary format. So if you look at the key findings report, pharmacy plan spend, so your plan spend in pharmacy at a per member per year is down by 2.3%. So it's running at about 1571 compared to a norm of 1652. So that's in line with what we saw when we did the annual review earlier this year, and the negative trend continues even up through June of 2020. And when I go to the next page, I'm going to highlight really some of the continued improvements in trend that you're seeing as a result of some of those changes that Julie mentioned. So you made changes to your formulary, to the mandatory generics, to the network to make it a mandatory CR90 now, to the utilization management. All those changes that you made in 2019 continue to help attenuate trend. Now, what you will see when you look at the key indicators, when you break out the plan spend between specialty and non-specialty, you'll see that the trend is that specialty pharmacy, and specialty pharmacy is some of the high-cost medications that treat arthritis, that treat cancer, that treat multiple sclerosis. That's where we are seeing the trend, close to 20% trend. But that's been attenuated by an almost 15% negative trend on your non-specialty. All right. Right below that is the member cost share. So the city is paying about 88% of the pharmacy spend, and the members are paying about 12%. So the member cost share went down slightly from 13% to 12%. And just, I provided some comparison to the norm. And the norm, the norm is book of business of Cigna of public administration clients. The book of business norm on the member cost share is about 9.8%. So that gives you an idea of how similar clients, their member cost share is compared to the city. And then just finally, again, the result of your plan show that your generic dispense rate at 90%. Again, that's a great indicator of all the things that you've put in place. So what I did was I put just some highlights on some of the things that we're seeing in your utilization. Cancer is your biggest driver in pharmacy. So we have about 3 high-cost claimants that are on cancer medications. One thing to remember with cancer treatment is that we've shifted from getting medications paid on the medical that would have been chemotherapy. As advancements have been made, that cost has shifted to pharmacy with the new drugs that are now oral that would be paid under the pharmacy, and that's what we're seeing. So we're seeing a couple of high-cost claimants on the cancer side. Apart from that, all the other conditions are actually seeing a negative trend. So when we look at your diabetics, we categorize them in 2 different ways. Those that are taking insulin, those that are taking hypoglycemics, or what we would consider non-insulin. And about 8% of your members are diabetics, and about 80% are taking the non-insulin. And that's typical. That's nothing out of the ordinary. That's typically what we would expect, because insulin is something that comes as the disease progresses. So you don't have as many highly progressed diabetics in a typical population. And then finally, we continue to see some decrease in some key classes, in particular asthma. We've seen some new generics come to the market, and that's helping drive your trend down. So overall, most classes are seeing an increased trend. The one class that we're seeing an increase is in cancer. I'm going to pause to see if there were any questions before I move to the third page. Okay. So the third page is similar. It's a similar theme. It's still the executive summary, but it has the raw numbers behind it. You can see the bar graph right there is where I mentioned how your member cost share has decreased from 13% to 12%. And you can see how that compares to the norm. If you go to the detail under your drug mix, you will see the impact of all the changes that I mentioned that you put in place in 2019. Formulary changes, the utilization management, the mandatory generics, all those have driven a generic dispense rate of 92%. That's best in class. That means 92% of prescriptions being paid are generic, which is what we want because those are typically lower cost. Right below that, you'll see that in terms of your network, we've seen a shift to the highly discounted Cigna 90 now. So those are the 90-day retail pharmacies. So about 50% of the retail of your prescriptions are actually going through that network. And that's really what we want to see, is that shift to the Cigna 90 now network. And then finally, in terms of your specialty, which is the bottom category, there, what I wanted to highlight was the shift that we're seeing. Your pharmacy specialty plan spend has gone up, but your medical specialty plan spend has gone down. And that just goes back to the point of how that shift in some of those medications would have been paid on medical is now shifting to pharmacy with some of the new drugs in the market. So pause there to see if there was any detail that you wanted me to cover before I hit on some of our recommendations. Okay, so one thing Julie asked me to do was really to point out what recommendations can we put in place, and we can actually put this in place 1/1 of 2021. So to start off, if you go to the page right after the recommendations, it's titled Proprietary Claim Engine. So in 2021, and this is something we talked about slightly in the annual review, Cigna is moving clients to our proprietary claims engine as part of the migration or as part of our acquisition of Express Scripts. So Express Scripts has the claims engine, and with that, we're able to add programs that we didn't have available before. We're able to add new solutions that were not available to the city before. One of those is in the affordability on diabetic medications with a program called Patient Assurance that I'm going to touch on. The other is on 2 new specialty solutions that target how we manage pharmaceutical assistance dollars, pharmaceutical copay dollars, or pharmaceutical coupons for specialty drugs. Those were solutions that we were not able to do, but because of the claims engine upgrade, we're able to provide that to you. Another one is an expansion to the gaps in care. We're able to add that automatically, 1/1/21. It would increase the gap closure, which is identifying opportunities where we can better manage prescriptions on the pharmacy side, increase gap closures by 30%, and drive an increase of about 63 cents PMPM in savings. So that will be added automatically. So with that, that's what lays the foundation for the recommendations that I'm going to go over in the next page. So if we go to the next page, which is going to have 3 key recommendations I've highlighted. So to start off on specialty medications, So with your specialty medications, as I mentioned, that's where we're seeing a driver. Specialty pharmacy drives about 44% of your pharmacy spend. Now, we have two new solutions. The first one is called Save On. So Save On is a vendor that we've partnered with that allows us to maximize the pharmaceutical coupon that may be available for certain specialty medications. So if you think about specialty drugs, these are medications that most of the city, they don't go to a retail pharmacy to get these medications. They get these medications through our specialty pharmacy at Credo. And for some of them, they may or may not know that there are additional pharmaceutical co-pays or pharmaceutical manufacturer assistance available. What Save On does is Save On outreaches to the member. They enroll the member on the pharmaceutical assistant dollars available. We maximize the amount. So we maximize the total amount that would be available through the year. And the cost share for that member is reflected for that maximized amount. The member ends up paying zero because we take the full amount. Save On makes sure that the full amount of the pharmaceutical covers what the member would pay. And then finally, that cost share is not counted towards your deductible or out of pocket. So this is how it's a big savings from maximizing the pharmaceutical assistant dollars available, ensuring that that cost share does not get counted towards the deductible out of pocket, and then the member pays zero. So the plan gets the savings from the maximized savings as well as the member pays zero. So we target about it's about 95 specialty drugs, and your client savings, I put it in there. The Save On client savings is 127,000. And currently, from current utilization, it would impact 15 customers. So that's Save On. I'm going to go to out-of-pocket adjuster. Out-of-pocket adjuster is very similar to Save On in that it would make sure that the client intent is implemented. What do I mean by that? If a member is getting a copay, if a member has a copay of $100, they have a coupon that pays $95 out of the 100, they're only truly paying $5. Out-of-pocket adjuster ensures that only that $5 is counted towards the accumulators, meaning that $95 does not get counted towards the deductible out of pocket. With out of pocket, there's no limit in terms of it's only on any specialty drug that would have a copay assistant. So it would be greater than the 95 specialty drugs that would be limited on Save On. And then in terms of your savings, you're looking at 42,000 annually, and currently, based on current city employees and members, there have been about 35 customers that have used copay assistance through Accredo. So that gives you an idea of the type of impact to expect. So in total, between those two programs, you're looking at about 169,000 in savings by adding Save On and the out-of-pocket adjuster. To round it off, in order to implement those, there would be a requirement that you change the specialty field to be Credo on the very first field. So right now you have an allowance of one retail field. This would need to be changed to allow a Credo at the first field. And that's the only way we can implement these programs is through a Credo. And get the savings in addition to all the clinical management that happens with a Credo. So I don't know if
Cindy,
I should pause there, and I can see, Mike, you have a question.
I've got a question,
Okay.
Patrick. So
Okay.
if we implemented that first fill, I mean, would be at a Credo, that's only on specialty. That's not gonna
That's
be.
correct.
Okay, so, which would probably be worth it, because we know that the specialty is a big spend anyway. But I just wanted to make sure that that first fill would be applying only to specialty drugs.
Correct. Correct. And actually, what we've seen is it provides for a better member experience, because today what happens is, for some, you have that one field, but at the second field they have to go to a Credo. So you're just delaying that move to a Credo, which in some cases creates a gap in care whenever they go to that second field. There's actually a better member experience if it happens on the very first field from our own data.
Well, sorry about that. All right, so I think what the problem has been around that, on the specialty, is people felt like there was a lag in getting their medications when they first need it. And how could we take that? I don't think that a Credo, I think that they are pretty quick on that, but I think making the member feel a little bit more comfortable that it's not going to take 2 weeks or something to get that first fill. I think that's why people go to their pharmacy, is because they want it quicker.
Yeah, and in most cases, the pharmacy typically doesn't stock these medications. So in most cases, there would be a delay at the retail pharmacy, because if you think of some of these medications, the cost is so high, a retail pharmacy wouldn't stock some of these high cost medications. They would need to have it special ordered, which would create a delay, and it's actually a longer delay than they would through a Credo.
So I guess that's just going to be that would be a member education piece.
Correct. And we have member letters that we can share with the city on that piece, as well as on both programs. So we can share the letters on both the save on and out of pocket that the members would receive.
I know it doesn't sound significant, but I'm always looking for these things in the plan, whether they're major or not. That's a cost saving, plus it helps our members. And it sounds to me like this plan is one that would help them as well as the plan itself. It helped the members as well as the plan.
That's correct. That is correct. Okay.
So Patrick, just let me clarify on this proprietary claim engine with the upgrade. This is an automatic upgrade, or is this something that we have to elect?
It's an automatic upgrade.
Okay.
It's something that's happening behind the scenes, and everything is being preloaded. So the plan design, everything that the plan design and everything is being preloaded. So there's nothing that the city needs to do. The only key change is that we will be sending all members new ID cards. Okay. And the ID cards will have some unique numbers that you'll need to present that at the pharmacy.
Okay.
Yep. So that will be the only key change, is the ID cards and the fact that you'll need to present that at the beginning of the year.
Jennifer, real quick, with open enrollment coming up, is that something that we can help educate some of the members on, that they will be receiving new ID cards, and to make sure that whenever they go to the doctor or the pharmacy that they're presenting those cards so that everything's running smoothly? Is Jennifer still there?
That is something we can put in the open enrollment guide. Are you saying, Patrick, that this will be a separate prescription card, or are you saying that it will be on part of the medical ID card and you'll reissue that?
Yes, yes, it's still gonna be the same part of the medical card. So it's just gonna have it's gonna have different numbers at the bottom, an RX bin number and a PCN number. Those are the two numbers that will be different. And those are the numbers when you give a pharmacy, that's what they typically put in when they're putting in your ID number.
So every member will be issued a new medical ID card from Cigna.
Correct.
And with a different member number? Or the
No,
same
no,
number?
no. Same member number. Same member number.
Okay. Okay. And when they show that card to the pharmacy, then they'll know to use a Credo? Or does the doctor coordinate that?
Yeah, that's something that the doctor would do that. And that's something that's already happening today. So that has nothing to do with the claims engine. So even today, a Credo is still the specialty pharmacy. Your specialty members are still using a Credo even today. So that doesn't change with the claims engine.
We're just changing how quick they move to the Accredo system.
Right.
Yeah. So it's something that's already been implemented, Terry. So we should be good there. I think as long as we inform our members that they're going to be getting new ID cards and to make sure to present those to the pharmacies, because that'll be the only part that changes. Will be the pharmacy side. Your member number and anything like that won't change. So that won't change as far as your doctor visits or anything like that.
Right. Right.
Okay. Does this affect our Medicare retirees?
Yeah, good question. So the data that I'm going over is only your active and non-Medicare retirees. So all this data was only specific to your active and non-Medicare retirees. So those two solutions that I mentioned on Save On and Out of Pocket are not available to the Medicare, and that would be separate. But the information that I'm covering does not impact the Medicare population.
Can I ask a quick question on the out-of-pocket adjuster?
Sure.
Since the bulk of the people are on the OAP1 plan and there's the $200 copay, that's really the piece that they're going to end up paying, or they're going to end up losing that added to their out-of-pocket. Is that correct?
Well, right. And it's better to think of it as the true client intent, which is only counting what they truly paid.
Right. We've seen this a lot on the high deductible plans, but I haven't really seen it impacting or being adopted on copay plans. So I was trying to come back to your 47,000. So that's kind of where I'm trying to wrap my head around it. So it would be if they have a copay card and they're paying $5, they'd get the $5, and they're currently getting the $200 applied to their out of pocket. Okay.
Correct. That's correct.
Okay, I'm going to argue that those savings are not going to be true savings, but that's okay, because right now the copays are a separate accumulator for the out of pocket than the medical, and I don't think there's probably anyone that actually reaches that. So I think I'm all for it because it's the right thing to do, but I'm just concerned that the savings might be overstated.
Okay. Patrick, the next part on there is the diabetes medication affordability, or how does that work?
Right. So the patient assurance, what that does is it caps certain medications at a $25 copay. So I believe today your tier 2 copay is $40, and you can correct me if I'm wrong. So for most of those branded insulin and some of those branded diabetic medications, it would cap their copay at $25 to provide more affordability to some of those medications than what they're paying today. So it would be $25 for a 30-day supply, $75 for a 90-day supply. And the reason why we're able to do this is we've partnered with certain pharmaceutical companies. They're providing means to offset that that copay shift, that copay decrease. And for the city, for you to implement that, it would cost you nothing, because the dollars that we're getting back from the pharmaceutical companies is what we're using to offset that decrease in your copay. So in effect, what you're doing is reducing the copay for some of these drugs to $25. It doesn't cost the city anything, and the members are going to pay slightly less than what they're paying today. You're looking at about 80 customers that would benefit from patient assurance. So that's the affordability, and that's also an additional program that was not available before, and will be available once we move to the claims engine, to the new claims engine.
So that's part of the claims engine, and we don't have to do anything on it as far as that goes. January 1, that goes live, and that's taken care of then.
For the patient assurance, because it's a program, we will need to have you sign off if you do want it.
Okay.
It is an opt-out. Basically, you'd be telling us if you don't want it, but in most cases, most clients are adopting patient assurance. Okay. And again, just to summarize, where you were in 2019 is you made most of the key changes that we will be looking at. Your formulary, your generic, how the generic is managed, the network, the utilization management. You made those changes in 2019. We're now recommending some new saving opportunities that were not available before. And you can couple that with some of what you're looking at in terms of employee contribution. When I look at pharmacy, that's how I would look at in terms of how to impact your spend moving forward. All right, and then the additional pages just provide additional detail behind the programs that I just mentioned.
Okay. Well, thank you for your work, Patrick, and thank you for your time. This information is useful to us, and we appreciate Cigna going above and beyond and finding these programs to help us save a little bit of money. I really like the diabetes medication affordability, that patient assurance program. I know it doesn't save the plan a lot of money, but it'll help put a little bit of money back into our members' pockets, especially the way everybody's seen in the media recently, the way diabetes medication is just skyrocketed off the charts. So anything we can do to help them, that I think that's a positive.
Exactly.
Can I ask one question real quick? Some of the diabetes medicines that you listed in that information that's behind that, such as like the Forxiga and things like that, the members are already able to get those at no cost if they just fill out the paperwork and put it to their pharmacist. How does that affect them? Are they still able to do that? Or are you still going to charge them the $25?
They're still able to do that. So yes, I do realize that some of those programs are available. So they're still able to do that. That would not impact what we're providing. Again, it would just be it's an additional incentive, especially if you're considering making copay changes. if you're considering making copay changes, it would be something that would really help if you were to say, okay, even though we're making copay changes for some of those diabetics, we're gonna provide you with that $25 copay cap.
Okay, thank you.
Right. You're welcome.
Does anybody have any more questions over the two programs or any further discussion? Sounds like the specialty or the proprietary claim engine, that's an automatic upgrade. And my understanding is we'll have to make a recommendation to the city manager's office to accept the patient assurance program to the affordability for the diabetes medication.
I'll make that motion, Mike.
Okay. Jeff will make the motion.
I'll second.
Jamie will second. To implement the patient assurance program to improve affordability for diabetes medication. All those in favor say aye.
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 Anybody opposed? Hang on, I'm checking on my chats and my text messages. Okay. Motion's approved. I will get that sent over to the city manager's office sometime today and see if we can get moving forward on that. Okay. Back to.
Then our specialty med stuff's gonna be separate, Mike, or are we gonna just?
Are you talking the proprietary engine?
No, the two things on the specialty med.
Patrick, correct me if I'm wrong, but that was all rolled into the proprietary claim engine, wasn't it?
No, even an out of pocket would need the same.
Okay, I'm sorry, I misunderstood that then. So yeah, we'll need a motion on the specialty medications as far as the Save On SP program and the out-of-pocket adjuster as well. If that's something that we want to do.
I'll make the motion again.
Jeff makes the motion. Do we have a second?
I'll second.
Seconded by Cindy for the Save On SP program and the out-of-pocket adjuster. All those in favor say aye.
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 Anybody opposed? All right. I will get those two recommendations sent over to the city manager's office and get those, hopefully we can get those implemented and everything running smoothly on that. Back to Lockton's presentation as far as deductibles, premiums. What's everybody's thoughts on this? I mean, where do we want to go from here? I know it's a lot of information to chew on.
So, Mike, go ahead.
Terry made a comment. He's unable to audio. He doesn't have audio set up. His recommendation, or he mentioned, write it out for a few months, or let's chew on it a little bit longer. I just wanted to make sure his voice was heard too. So, any other comments?
I agree with that. I would like to see if I'll just be honest. I don't even know what kind of percentage increase would be necessary to help us out. So I don't know if Lockton could put together those kind of suggestions or give us some, if we did a 3%, what that kind of cost would save us, or did I miss that in here, or?
Well, I think between their projections and for claims through March, on the third page of their presentation, the first column is the 2021 projection, which is claims through March, and then 2021 projection claims through August. I think they're really recommending anywhere from about a 14 to a 20% increase. Is that correct, Dina?
That is correct. That's what we would recommend.
Okay.
I see that. But I'm just going to say, you make a 14 to 20% increase, Mike, and you're going to have a complete revolution in the city. I'm just going to tell you that right now.
Well, I understand that, and it's unfortunately we're put in this position, and sometimes it makes tough.
I will say, if you look historically, our recommendations are always higher than what the city does, and we tend to be conservative. So, but I have to follow my actuary's instructions here. So, on paper it says 14 to 20. That's all I can say.
I understand.
And this is a really tough pill to swallow. You know, with everything that's going on, I know there hadn't been a lot of pay increases in the city, and this is really going to hurt. This is going to tap into people's bottom dollar. You know, maybe it's something we chew on for another month, and we get another month worth of claims data, and we go from there. I don't know. Jamie, what are your thoughts?
Well, I'd like to see another month. Is there any way open enrollment somehow share this, that things could possibly be changing next year, not for the better? And it's just math. You can't keep spending the money. But I'd like to see what happens too.
I mean, I think we owe that to the plan and the members to do a little bit of due diligence and see what happens. I mean, we've made mid-year plan changes before. You know, I don't know. I think it's something that we start talking about and informing people that this is a possibility of coming, and see how it plays out.
Thinking open enrollment kind of experience in August, if that continues, we're going to be in a tough spot.
Yeah. Cindy, what's your opinion? You've been in this for a while, and you've been through the ups and downs with us.
I'm concerned. I was concerned when they didn't put in the budget an increase, because I've been on this committee for 20 years, and I've seen every time that we do this and don't take an increase, our plan takes a nosedive, and it's hard to recover. And the last time that we did that, the city went in a hole with the plan, and they graciously, and I say that graciously, went ahead and fronted, that money until we came out of it. But I think we got to be careful about doing that, because it's a whole different administration. So that makes me nervous.
Well, it's a different administration, and we're in different financial times too.
Yeah.
Tammy just replied in that she said that she thinks she'd like to see another month's worth of claims data too. That's kind of the consensus that I'm going on, or that has been spoken in the committee between Terry and Tammy. Jamie and Jeff have expressed it. It's a tough call.
And I think we have to go with the majority, like I said, that's just my opinion, that we really need to start looking and diving deep into the numbers, because I'm fearful. I mean, we can wait a month, but I'm fearful that if we don't try to take some sort of increase, that's where we're going to be.
Dina, are you still available?
Yeah. What do you mean, am I still available?
Oh, I was just making sure you were still on here. I know there's a lot going on.
Oh,
Tammy
yeah, I
asked-
sent Amber to the other meeting. I stayed on this one.
Okay.
We're dividing and conquering.
There you go. Tammy asked a question. How soon does the data get calculated for September? How soon do you guys have that claims data for September, and maybe potentially meeting a little bit sooner than waiting another month?
Yeah, we usually get it between the 12th and the 15th.
Okay.
So we can turn it as soon as we get it and
move up our meeting in October.
Yep.
Yeah, I mean, that would move our meeting up. We could move our meeting up to the third Wednesday of the month. I'd have to talk with Steve Wagner and make sure that he's available that day and everything.
Or just
like that.
have planned 2 meetings in October, one for the 3rd and one for the 4th, just to go over the new numbers, and that way people have a week to think about it between to vote versus.
Okay.
Just a thought. I'm not a voting committee member, but it seems like that might make sense.
That doesn't sound like a bad idea. What's everybody on the committee think about that?
That sounds good.
I agree, because we've had to call special meetings before to make decisions like this. So it wouldn't be bad just to get it on the books.
Okay. Well, sounds like that's a consensus on this. So we'll kind of table this for until October. I'll get an email out here in the next week or so about meeting on the 21st as well, and set all that information up so that we can look at some of these numbers through Lockton and go from there and see what we can do and see how things kind of level up. Cindy, I've got to go. We're going on a structure fight.
Okay. All right.
Hey, Cindy, I have a question. Is there a way for us to, or could you invite Zach or one of his assistant city managers or even Brian to the next meeting so we can kind of see what the city thinks about all this and what they may be willing to help with?
Of course. I know they always get the invitations and everything, but yeah, we can try to reach out and say that we think it's pretty important that somebody sit in on that meeting.
Yeah, I think one of those decision makers needs to be at that meeting to help us in making these decisions.
Okay. Does anybody have any other new business, or do we have a motion to adjourn?
I'll make a motion to adjourn.
Okay, Jamie made a motion to adjourn. Do I have a second?
I'll second it.
Okay. And all those in favor say aye.
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 Any opposed? All right, motion to adjourn, and we'll reconvene next month.
Okay, thank you.
Uh-huh.
Thank you.